Welcome to the Healthy Human Revolution podcast. I am so excited to introduce Dr. Nicole Harkin. How are you?
I'm so good. How are you doing?
Good. And we met recently, and I'm just tickled to meet you. And I've just been impressed and really enjoyed speaking to you. So I really want to share all the amazing things that you have in that noggin of yours with you're a cardiologist, life in plant-based is just a beautiful thing. So I'm so excited for people to understand your story and everything about you. So Nicole, can you tell us a little bit about maybe just kind of what made you want to become a doctor to begin with?
Oh, we're going to start way back. I love it.
Oh yeah. Oh, please. You're young and come on.
So yeah, I became interested in medicine. I definitely was not one of those doctors that had this, I knew from the age of 5 I was going to be a doctor. I definitely was just always interested in science. And I actually went to an all girls high school. And I really think that I have to give them credit. I didn't fully realize the impact it would have, but I think definitely allowed me to be more just excited and interested in my science classes, particularly biology, and just was really, really interested in biology. And that kind of continued into college. And actually, I entered college thinking pre-med. And then I took general chemistry and I hated it. I was like, this is not for me. It's not meant to be. I actually dropped the course. I mean, it's just like done. But I actually continued with some of my biology courses and just loved them. And my professor was like, you're crazy. Like you're good at this stuff. You like this. If you want to do medicine, you should do it. And then randomly organic chemistry, I like really, really liked as well. So I was like, okay, maybe science is my thing. So ended up doing general chemistry over the summer and continued on to the pre-med track. And then did a lot of actually international work. And throughout medical school, I really thought I was gonna maybe do more of like a public health kind of thing. Or maybe infectious disease. So ended up doing a lot of work in Central South America and abroad, and just really, really enjoyed the interaction with the patients. And then eventually, when I was in residency at Columbia, which is a very cardiology heavy program, was when I think I kind of got inundated with cardiology, and I was like, this is cool, this is exciting, this is what I want to do. And I loved procedures, and then just most importantly, kind of getting back to the public health aspect of it. It's the number one killer of men and women across the globe, right? And so just this idea that you could have this massive impact on the health and well-being of people just really drove my interest. And so went to fellowship at NYU, which is a very, cardiology is an intense fellowship experience. It is fully immersive and you are just in it. But throughout this have always been interested in sort of population health and prevention in general. And so had the opportunity to work with the prevention department at NYU, and was my last year of fellowship, spent a couple of months just rotating through that program with them. So I'm a non-invasive cardiologist, which means that I don't do procedures anymore. I'm a just general cardiologist, but consider myself very much a preventive cardiologist. That's my passion. And then I'm actually also a lipidologist. So also was decided to get boarded in the study of cholesterol. So that's sort of my training and my path to becoming a cardiologist. And out of fellowship now 5 years, and a very worked in private practice for the last couple of years, and then recently relocated with my family to San Francisco. And so been here for a couple of months now, and launched my own preventive telecardiology practice.
Awesome. There's so much to ask. So after we spoke and you talked about, being a lipidologist, and I spoke to another cardiologist, and I was like, I wonder if there's a way, like, is there classes or something for a primary care doctor? Because I get a ton of these questions, like, they come to us first and then we send them to you guys typically. And so the National Lipid Association, they have some tracks for primary care docs to do similar type of board certification. So I'm working through that. It's a fascinating thing. So I definitely want to talk to you about that. And I'm bringing on Dr. Kim Williams and Eugenia.
Gianna.
Yes,
He's my
Gianna.
mentor. Yeah.
Oh, yes, that's fantastic. I'm bringing them on together in February, but I really want to prime this conversation and get as much information as out as possible because I get so many individuals and patients who are plant-based, but are still having high cholesterol. So maybe we can just kind of dive into that right now. But first, before we get there, I would like to know your plant-based journey, how you decided to go to a plant-based type of a diet.
Yeah. So let's see. It started actually not sort of in relation to health, interestingly. So and it's funny because I didn't fully realize how instrumental, sorry, did
That's
I lose you
okay.
there?
No, you're good.
Those earbuds. So it's funny because I don't know the exact date, and I didn't fully realize how instrumental sort of this experience would be. But um, it was about 10 years ago when I read a book called Eating Animals by Jonathan
Mm,
Safran Foer. And it's more kind of the exploration of sort of the culture of why we eat the certain animals we eat, and then really just dives into sort of industrial farming and all of
mm.
that. And this is also in the backdrop. I should, in full disclosure, I have to give my sister a shout out. She's a veterinarian, and she been a vegetarian for eons, and so she'd sort of been planting the seeds over the last handful of years, and then read this book and just was like, "That's it. I
Mm.
cannot contribute to industrial farm anymore. I'm done eating meat." So that's when I had my last bite of meat. I had one weird craving for chicken wings, like in my first, it was so weird. In
Was
my
it
very first,
Chick-fil-A?
yeah, and no, like just like a buffalo chicken wing. And
Okay.
I didn't fully, realize I probably could have just done cauliflower and been satisfied, but it was this weird craving in my very first pregnancy. So that's actually probably the last time I had meat. Um, so yeah, that's kind of where my plant-based journey started, was actually more, from an ethical and
Mm,
environmental standpoint. And then I would say at some point throughout my fellowship, when I was involved in the prevention program and actually, working with Eugenia and everything, it's definitely, I would say, most cardiology programs, there's a little bit more of an emphasis on kind of Mediterranean diet and things like that. But there's so much overlap, the
mhm.
commonality being obviously lots of plants. And so just really interested in prevention. And that's when I started getting more fascinated with sort of the implications of nutrition and that overlap with cardiovascular prevention.
Awesome.
Just started doing a lot of self-study at that point and just delving into the literature. So with Eugenia, actually my research project at the time was we looked at both internists and cardiologists in terms of their knowledge of nutritional science and their interest in it and all that stuff. Yeah, and then just over the years have just become more and more and more plant-based and really interested in helping my patients on those journeys as well.
Fantastic. So, can we just start with the conversation on what is cholesterol? I mean, let's just get down to the basics and just kind of build from there because I think, a lot of people are maybe even confused at exactly what cholesterol is and what its function is in the body.
Yeah, so it's a fat-like substance that is important for our body, right? We use it for vitamin D and steroids and hormones and all kinds of things. So it is important in our body, but when we have too much of it, it is the primary driver of what causes blockages in our arteries. And cholesterol, how we measure it in what's called a lipid panel. That's usually how most patients will sort of see their cholesterol. So when their doctor's checking their cholesterol, that's what they're drawing is what's called a lipid panel. And we're looking at the amount of cholesterol that's contained in various lipoproteins, which are basically just vehicles or little transporters for our cholesterol in the body. And so we get a measure for our LDL cholesterol, which is the bad cholesterol. And that's typically the cholesterol that gets that is in our bloodstream. And if there's too much of it, deposits in the arteries of our heart and elsewhere. And then and that's called the LDL cholesterol. And then we have the good cholesterol, or the HDL. which is the type of cholesterol that's contained within the lipoproteins that tend to shuttle back to the liver to get processed out. So those are kind of the two forms that we end up, and then there's the triglycerides, obviously, and that's the fatty acids and things that are in our body as well. So that's sort of the bare bone basics of how most people interact with cholesterol.
Mhm. And when you're looking at that panel, or patients looking at the panel, what number should they be? I would say optimal, because we could talk about the different things and risk factors here in a second, but what would be an optimal cholesterol panel or a lipid panel would you suggest?
Yeah, so the primary number that we look at the most right now is the LDL cholesterol. And we can even get into the various ways that we can measure all the bad cholesterol and things like that. But how most patients will interact with it is this LDL cholesterol in the standard panel. And we like to see that optimally below 100 milligrams per deciliter. For many of our patients, we like to see that even lower. As a cardiologist, most of my patients who have established heart disease or a lot of risk factors for heart disease, we like that to definitely be below 70.
Okay. And then, so when there is some, I feel so bad for our patients because there's so much confusion when you hear about cholesterol is not bad, it's not good, it's okay, whatever. You hear all these things, and diet doesn't affect, LDL is not important. So when you're talking about diet in respect to your cholesterol, what can we see? How much does it affect it? Is it something that someone should be aware of? And what was your advice to patients from that standpoint?
Yeah, this is definitely one of the topics in our field that has suffered the most from controversies and misinformation, and some of that stems from our evolving understanding of how diet does impact our cholesterol numbers. So, the simplest way, kind of, to break it down in terms of what impacts our cholesterol numbers the most, for most people, that's saturated fat.
Mm.
So the consumption of saturated fat gets, absorbed into the body, and then from there the liver can package that all up into cholesterol that gets transported throughout the body. So by eating less saturated fat, the liver actually seeks out other sources, and so it'll increase the little receptors that go onto our liver to suck it back out of the bloodstream. And so actually that's a very potent way that we can lower our cholesterol, is by swapping out saturated fat for other things. What we see in the research is, if you swap it out for monounsaturated fat, complex carbs, and polyunsaturated fat, we see that those numbers come down nicely. In terms of dietary cholesterol, that's definitely been the subject of a lot of controversy. We do know that it matters. It matters probably differently for different people and in consideration with what. But the good news is if you're focused on lowering your saturated fat, you're also going to lower your cholesterol. And so while it is true that the main source of cholesterol within our body is what our body's making, not necessarily what we absorb from our diet. There are many individuals who actually absorb a lot more of cholesterol from their diet. And so it's just based on the transporter in the intestines. But to keep it pretty straightforward, if you lower your animal products, you're lowering both.
Okay. So most of the time when you're talking about saturated fats, these are going to be coming from animal products, cheese and dairy, meat, even some fatty fish, I'm assuming, would have higher levels of saturated fats versus others, but those also contain the cholesterol. So it's hard to maybe figure out exactly where the dietary cholesterol with saturated fat, and where those lines cross. I mean, how would you study that? I would be curious. If you eat dietary cholesterol, how would you measure that it's strictly the dietary cholesterol, or is it the saturated fat that's a partner with it and kind of comes with it in the one package?
Right. So I think a lot of it comes from the epidemiologic studies where they try to account for the cholesterol intake and things like that. But you're right, it's very difficult to sort of sort out the two. And then mechanistically, we also know sort of how each one works and things like that. So if you block the uptake, like for instance, Zetia, like you can block the uptake of cholesterol, right? So you can mechanistically look at how different things affect your body in different ways.
Fascinating. So definitely saturated fats, and then some individuals with the cholesterol. Because I mean, even myself, I've seen patients, I think the biggest one that I ever saw that really stood out was in 30 days after going to a plant-based diet, his total cholesterol dropped 120 points. Granted, it was just right around 300, but it was really quite remarkable to see even what 30 days could do. And then as far as the heart disease burden, what does a plant-based diet do as far as, the atherosclerosis? Is there regression? Is there not? Is it, what did the studies say, or what does science say about the heart disease risk in dietary saturated fats cholesterol?
Yeah, so we see really powerful results when patients move towards plant predominant or plant-based diets. So we at this point have lots of both epidemiologic, which is where you study whole populations and analyze what they're eating and what their life expectancy and their heart attack rates and things like that are. And then also randomized controlled trials, not all of strictly plant-based, but very plant predominant type diets. And uniformly, we see that the more plants, so for your listeners, I'm sure they all know this by now, but fruits, vegetables, whole grains, legumes, nuts, seeds. As people consume more and more of those, we see the risks of heart attack and heart disease and death from heart disease all go down.
Mhm.
And some of that is the decreased saturated fat. A lot of it's also the fiber, which we didn't talk about, but that also is really potent at lowering cholesterol. It kind of keeps the cholesterol from getting absorbed into the GI tract. Lots of antioxidants, phytonutrients, all that other good stuff that comes along with plants. And we're increasingly realizing with heart disease that while LDL cholesterol is very important, it is the primary driver of heart disease, inflammation is also really critical. And so, we really see that plant-based type diets or plant predominant diets are really anti-inflammatory. And so I think you're really hitting the cardiovascular disease perspective from multiple different modalities and approaches when you increase your plant intake.
So that's fascinating. So when you have someone who comes to see you, let's say that they either have high cardiac risk factors or they've already had an event, but maybe a stent or something, what do you look for? Like, what lab tests do you order? What should someone expect to see when they come to see a preventive cardiologist? Like, what should they have their mindset to discuss, or maybe what should they bring to the appointment too? Like, what information would be helpful, just kind of in preparation for something like that.
Yeah. So first and foremost, certainly a full history is just critical. So not only medical problems and medications and supplements and things like that, but family history, right? So a strong family history, which for us cardiologists is a first degree male relative who's had a heart attack or a heart event before the age of 55, and a female first degree relative before the age of 65. That becomes critically important. Personal for women, definitely menopause history, so early menopause, or gestational hypertension, preeclampsia, or pregnancy complications. These are all risk factors for heart disease. And then other medical problems that people might not think of that are also associated with increased risk of heart disease or inflammatory disorders, lupus, rheumatoid arthritis, things like that. So having a really good comprehensive history of all of kind of your medical problems and concerns. Symptoms obviously are very important. And then your current sort of lifestyle. Diet is obviously a big one that I touch on. What are you eating now? Do you restrict anything? All of that kind of stuff. But then all the other things that we are increasingly realizing from a lifestyle perspective are really important for cardiovascular disease: stress levels, sleep, all of that. Obviously, physical exercise, sedentary behavior, all of that kind of stuff is part of the really comprehensive history that I take. And then we also, as you mentioned, look at a lot of lab tests as well. So above and beyond the standard lipid panel, which is quite good for many people, and for low risk individuals, that's often sufficient. But for many of my patients who are really looking to drill down and optimize, I do a more advanced lipid profile, which essentially is looking at not so the standard LDL cholesterol, when you get that number, that's looking at how much cholesterol is in that LDL particle contained. And this is increasingly becoming more of a problem as we see rates of obesity and insulin resistance and all this go up. We're seeing an increased discordance, meaning that you can have different sizes of these cholesterol particles. This is getting a little complicated,
No, it's good.
but
It's
it's
good.
important. I think it's really important that people understand it. So you can have different sizes of cholesterols, right? So you can have these big fluffy LDL cholesterols or lots of small dense LDL cholesterols. And because of the different sizes, you can have the same amount of LDL cholesterol on that standard lipid panel, but have very different LDL particle numbers, which are measuring those vehicles themselves. And in individuals where there's this discordance between the LDL cholesterol and the particle number, meaning they have higher particles than you would expect based on looking at their LDL cholesterol, the LDL particle becomes more predictive of their cardiovascular risk. So in individuals like that, looking at either the ApoB, which is the little protein that's on those vehicles, or actually measuring all those particles can be really helpful, particularly if you're really, really looking to optimize their risks. So I look at a lot of those kind of things. There's also something called lipoprotein A, which I don't know if we have time for, but I think is super important, that is definitely an increasingly recognized cholesterol issue, and it's quite common. 1 in 5 Americans may have a very elevated lipoprotein A, which is kind of just a fancy LDL cholesterol particle with a funny little protein attached to it. And for various reasons, it is more atherogenic, potentially than even LDL cholesterol, meaning it can cause plaque buildup, and it deposits plaque in the arteries and all that stuff. So everyone gets that measured for sure. And then different measures of cardiometabolic resistance, fasting glucose, insulin, all those kinds of things.
So let's go back to the lipoprotein, the little a, that is really curious. So what should someone be looking for? How can they lower it? Is there anything naturally dietary wise, exercise? Is this a genetic predisposition? There's nothing you can do. So what have you found that works in that category?
Yeah, so this could be like a podcast in of itself. But,
Yeah, I'm pretty sure it
right?
could.
I mean, it's such an interesting and emerging risk factor. But essentially, so as I said, it's a LDL particle that has this little protein attached to it, the apolipoprotein A. And so, like LDL, it deposits cholesterol into the arteries. So that's one way it's bad. The second way it's bad is that little protein that's attached to the LDL particle actually resembles something called plasminogen, which is a clotting factor. And so it increases the risk of blood clots as well. And then it's actually really strongly associated with aortic stenosis as well, which is the most common valvular disorder in the United States, essentially where your aortic valve, which is the valve that's between your heart and the rest of the body, and it opens when the heart pumps blood out. As we get older, that starts to get thickened, and that's somewhat normal aging, but many people get it becomes calcified, and that becomes aortic stenosis, and that requires a valve replacement. And so, elevated Lp(a), which is defined variably, but below 30 milligrams per deciliter is considered very, very normal. Above 50 is considered elevated. It's estimated that about 1 in 5 Americans have an elevated Lp(a). And it does increase your risk of cardiovascular disease by twofold, aortic stenosis, I think by twofold or so, and then blood clots like DVTs, the ones in the legs, or pulmonary embolism, the ones in the lungs, by about threefold or so. So it's an important risk factor. The Lp(a) cholesterol content is more or less captured in that LDL cholesterol, but I've seen so many people that come to me with these elevated Lp(a)s that didn't know and had either premature coronary disease or their family had premature coronary disease. It is by and large genetically determined, which is disheartening for many ways, because it's also not readily manipulated by diet. So how most of us at this point are approaching it. We don't have the only medication actually that can reduce it is the new drugs, PCSK9 inhibitors, which are not specifically approved for that indication. And we also don't have a clinical trial yet that shows that by lowering it artificially with a drug, we actually decrease cardiovascular risk. So we're waiting on those trials. In the meantime, most of us use it as a risk enhancing feature, meaning that if I see that, particularly if you have a strong family history, I am very aggressive about making sure that all your other risk factors are really, 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 really well optimized. We work a lot with diet. It's weird. Diet's a weird one. Actually, some of the studies have shown that all of our typical manipulations that you and I do to lower LDL cholesterol with diet actually help you a little, like goes up a little bit, which is just,
what?
I know. It's disheartening and you're like, okay. But we all, at least the experts in the field still agree that you should still, lower LDL with the proper dietary measures. But yeah, there's one study that I've seen that very small that actually did show plant-based diet lowered the Lp(a) a little bit. Anecdotally, I'll tell you that I don't see it move much in my patients. So we really focus on the LDL. We focus on the glucose. We focus on making sure they're not sedentary and all those other things that we know for the moment. And then hopefully in the next couple of years we'll have more therapeutics potentially.
So I'm going to give you a few patient scenarios and let me kind of give me some guidance. Let's say yes, this would be good. Yeah. So let's start with myself. And these are true numbers and facts. So biological father, first heart attack, 38. I don't know if he's had others. We're not in communication, but I was 18 and he was 38 when he had his first heart attack. Second to that, my mother's grandfather died at 46 of a massive heart attack, but he was a smoker, but that's all I know about that. But I am healthy other than hypothyroidism since the age of 24 when I had my kid, my second kiddo, or 25, somewhere in there. Well controlled, blood pressure is great, never been overweight, never pre-diabetic, nothing like that. Cholesterol is always under 150. My LDL is usually under 60. Triglycerides are like 30 something. My HDL is always over 60. So you have someone like that who's pretty healthy, but has this predominant factor. I haven't had my Lp(a) checked. I should do that for sure. What would be your first intention with someone like who's relatively healthy but has some risk factors? And now I'm perimenopausal. I'm 50. Any thoughts there?
Okay, so first of all, you're not pretty healthy. You're extremely healthy. You're in like the top 1% probably of healthfulness. So this is not exactly fair. You are not a normal patient.
Okay.
You're doing everything right. But the one thing I would say, no, I mean, you've done exactly so most patients are coming to me with that type of a history that are kind of like, I eat kind of healthy, I try. And that's where we really focus on optimizing all those things. And we can see that going down. And you didn't tell me your activity, but I know you run.
I run 30 plus miles a week.
So you're already doing all the things, right?
Yeah.
The one thing that, and you wouldn't technically at all fall into the guidelines of where we recommend this, but the one test that we haven't talked about yet that for many of my patients who are reasonably healthy but kind of want to know where they're at is a coronary artery calcification score. Sometimes I get those. Just because we see patients who have doing all the right things and because of these genetic issues, we do end up seeing surprising results. So in someone like you, you're actually kind of that perfect age range as well, where we would get the CAC or the coronary artery calcification score. So what that is for your listeners, it's a specialized CAT scan that looks specifically at the arteries in the heart. And it's protocoled now down. So the amount of radiation, I think it's like 1 millisievert at this point. It's about a mammogram basically. So, there's radiation. We're not doing these every year on people, but it's, not an extraordinary amount. And basically we can quantify the amount of calcium that's in the arteries of the heart. And then basically you're given a score, which is either 0, which is obviously wonderful. And there's been lots of trials to demonstrate that you can really change someone's risk up or down with these coronary artery calcification scores, specifically the zeros, right? So in patients who, this would not be you, but And many of my patients who are sort of at this borderline risk and we're really working hard on all the lifestyle things, but their LDL is still kind of like not where we want it. Do we start a statin? Do we not? That's where it can be really helpful. Because if there's zero, I feel very comfortable. We're at a place that you're doing all the right things. Maybe your LDL is not exactly where I want it to be, but there's not this like urgency. We have to start the statin now, because studies show with the coronary calcification score of 0, your risk of a heart attack or cardiac event in the next 5 years is very, very low. So that's one way it can be useful. And then in contrast to that, in people who you think are really healthy, but all of a sudden their coronary calcification score is over 100 or definitely over 300, or they're much higher in terms of their age adjusted. So you get also not only a number, you get a percent for your age and kind of where you compare for other women your age, say. And so if you're really off, then that can kind of be a wake up call of, okay, something's not optimized. What's going on. So I find those to be really helpful in lots of individuals. I'd say I want to just point out the one caveat being that it's mostly the most of the data is 40 and up. So it's not the most appropriate test for unless you have a lot of risk factors for the younger population. So the one thing I'll say is the coronary calcification score of 0, for instance, in someone who's 30 is not necessarily reassuring. I mean, it's good that it's 0, but just to point out that it's only measuring the calcification within an artery. So there's something called, so the evolution kind of a plaque is that once the cholesterol builds up into the artery, at first it's not calcified, right? It's called a soft plaque. And so we would expect that most people, if they do have plaque in their 30s, it's soft plaque. And so that isn't it picked up in the coronary calcification score. And we don't have a ton of studies to show that the CAC of 0 in like the younger population is as reassuring. So obviously if they have coronary calcification score, that's a huge wake up call for someone there in their 30s. But just to show that but it does miss soft plaque, right? And that's also important because as we're starting to use these more and more in terms of how often do you get them, we will see evolution of plaque even if you're doing all the right things. For instance, statins, they stabilize plaque, meaning they calm the plaque, the inflammation within the plaque. It's part of why they're so effective, not just in lowering cholesterol, but they're part of why they're so effective in lowering rates of heart attack. But what actually we see is that once you're on a statin, the CACs will go up a little bit because it's stabilizing the plaque, right?
Oh, wow.
So it's all that soft plaque that you had, say, in 2020, and then if I check you again in 2023, the CAC will go up if you're on a statin because it's calcifying all of that other plaque that you had.
Interesting. So is it actually beneficial to get multiple, CAC scores or just one?
Yeah, so it depends. This is where the personalization really comes into play. If your score is 0, we definitely would not recommend repeating it until at least 5 years. It kind of has a 5-year warranty such that those 5 years, as long as you haven't, there hasn't been any major changes in your lifestyle, that your risk of heart attack and stroke, et cetera, is low for those 5 years. If it's sort of like at the 100 and you're worried they're progressing more quickly, you can check it within 3 to 5 years. The guidelines say this is all very much still kind of in the workings of it. And then obviously if you have a 300 and up or established coronary disease, there's no point in checking it again, because it's not going to really change anything you're doing.
So now I've got another patient for you. So now we're moving up in evolution. So now you've got someone maybe has some other lifestyle factors. Maybe they were diabetic or pre-diabetic. Well, no, let's step back one more. I have healthy plant-based eaters who are strict whole food plant-based eaters. They're salt, oil, sugar-free, normal weight, exercise, but their cholesterol, no matter what we do, budges around between like 190, the low 200s. They may or may not have an elevated LDL, but typically closer to 100, maybe just over 100. Triglycerides usually are pretty low. HDL will vary between 40s, somewhere in there. I'm getting a cluster of these guys. but they have no symptoms. They've never had any cardiac events. Their first question is, do I start a statin? So where do you begin that conversation with those type of patients?
So what you said, the LDL or the total cholesterol?
Total cholesterol will usually always be, that's what usually gets people triggered, is it's usually above like 190, low 200s. They're in that range, and their LDL is sometimes over 100, but most of the time it's in that, definitely above 70, in that range. That there seems to be that cluster of patients that I see a lot of them actually.
Yeah. So most of us don't focus as much on the total cholesterol. Those are typically mostly I focus on the LDL cholesterol as my primary target.
Okay.
And then in people, if I'm concerned about sort of once I feel like, the LDL is optimized or not quite optimized or what's going on, that's where sometimes the advanced panel can be helpful, either checking an
Mm,
ApoB or checking their LDL particle, right?
gotcha.
So if to see if there's any signs of insulin resistance or anything like that as well. So around 100 is reasonable
Okay.
if all of their for an LDL, if all of their other risk factors are well controlled. So the total cholesterol in and of itself would not trigger me to start
Gotcha.
do anything.
Okay.
As long as all other things
All
are.
the other things are in order. And then there's others who maybe they were diabetic, no longer diabetic, or maybe they're in the process of eating well and their blood sugars are coming down. They're on medications and weaning down. Blood pressures are improving. So you have these people with some serious risk factors for heart disease, but they've not had an event. And they're very resistant to starting, maybe cholesterol. But when they're doing this and they're transitioning, maybe their cholesterol, their LDL is dropping down below 100. Would you consider these risk factors enough to say, yes, you probably should be on a statin? And when, let's say they reverse everything because, a year from now, they're no longer diabetic, hypertensive, normal weight, do you stop that statin if they've been on this statin? So if they had no cardiac events, like that's a big discussion too. You maybe get someone with a statin who's made these amazing lifestyle changes and now they're better. They're like, I don't think I need this statin anymore. What do I do? How do you begin that conversation?
Absolutely. And these are great cases because this is like where the art there's no specific one guideline to say
Yes.
what we should do with these people. So this is all where it becomes kind of that risk benefit patient conversation.
Mm,
We can explain what we know, what we don't know, what are the limitations. And this is where it gets really hard because guidelines are on a population-wide basis, right? This is what on a population-wide basis we should do, but for each individual, it doesn't tell us specifically for that one individual how they
mhm,
will. So, certainly individuals with diabetes are should be on a statin, period, right? So we know
mhm,
that. So, but what happens if they reverse their diabetes with
mhm,
diet? And and so I think it would also depend on family history, all their other risk factors, and then these are also, and then just sort of their appetite for risk, and versus their desire to not be on medications. And every patient's really different. I have some patients who they're at this borderline risk. So, you can put in all their current numbers into, say, the ACC-AJ
mhm.
calculator.
Cardiac risk, yeah.
Yeah, so we can kind of calculate their risk based on what the studies would have shown us a person with similar numbers, what their quote unquote 10-year or lifetime risk is. So a lot of times that's where I'll start. I'll put in the numbers and I'll say, this is what sort of the data shows us. This isn't, it may not be reflective of you specifically because your diet, you've brought this down with diet or whatever else. But I think that's a good starting point. And then kind of some patients, when they see, over in the next, 10 years, your risk of a heart attack is 5%, they're like, give me that statin. I don't care, and that's it. And that's great. That's their decision. Right. And then
Mhm,
other patients say, I really don't want to be on a statin. And then that's their choice as well, and
mhm,
that's where this borderline and intermediate risk group, if your risk is somewhere between 5% to 20% of having a heart attack or stroke in the next 10 years, these are the people that do benefit from advanced testing. So what's their high sensitivity CRP? What are the particle numbers? What is their coronary calcification score? We haven't talked about carotid IMTs, but those can be really helpful as well. So that's where you can kind of get some of these other diagnostics to sort of round out the picture, and then you present everything to them, and then you help them make that decision.
Absolutely. I think that's great because I mean, even recently, a patient with COVID who had been a long distance runner previously. So you have someone who's, let's say later 40s, had been very active, but now we've got this new kind of uninvited guest making their presence known. And we don't know what those long-term effects on, the myocardium, the heart health and what that's doing. So but they might have had some inflammation or myocarditis, some other things, and it showed actually some EKG changes, high cholesterol, wasn't aware, recent new to plant-based eating, and you put in their calculated score, and it's like 5.6 or 6, somewhere in there. I'm like, I think we need to start the stat until we know more about what's going on. But what is your suggestion when you have others that are kind of like, they're new to the diet. Cholesterol is definitely not optimal, but maybe they had COVID and they had some inflammatory response because they had an abnormal EKG where they had a normal before. Where would you begin that just kind of exploration, I guess?
Yeah, so I think in patients who I'm concerned about in a more acute period of time, I definitely am favor pharmacologic intervention early on, reassuring the patient we can always peel these back.
Yeah.
And it's one of my favorite things to do, by the way. So
Exactly.
you don't have established heart disease. It's my favorite thing to do. No.
Yeah.
So I think that definitely having that conversation with them that medications aren't necessarily lifelong. I have lots of patients who've come into me with, really high blood pressures or whatever else, but they're super excited for lifestyle changes. And for many of those individuals, I'm starting you today on 2 blood pressure medications because I do not want you to have a stroke.
Exactly.
However, I'm super excited that you're enthusiastic about these changes. They do take some time. And in some of those people are super, super enthusiastic. You do have to watch them very closely, like see you in a week kind of thing.
Yeah. Oh yeah.
And get some of those blood pressure medicines off. But a lot of people definitely don't always realize that just because I'm starting a medication doesn't mean that we can't stop it together in a controlled fashion. And so certainly I think erring on the side of caution when in doubt, with the idea that as we know more, we can peel things back. And COVID's a great example. It's such an emerging area of and so if you're concerned about people, I think certainly erring on the side of caution is reasonable. And just speaking about COVID, myocarditis is a great example of how we're still really learning a lot about that. And the big one would just be, cautioning with like excessive exercise and things like that.
Right.
So
Yes, which was part of a conversation. Yes.
yes,
Yes,
which I
very
know was
much so. Yes,
very
it was
hard.
very, very, yes, yes. But it was a very, yes, yes. That was a very big part of the conversation. So, I'm sitting here thinking of a few other things. I tell people all the time, because I'd say 95% of my patients are diabetic. I get a lot of diabetics in management of their insulin, and I'm getting a lot of type 1.5s, which are interesting, these late onset autoimmune type diabetes in adulthood. Really interesting how they evolve, and they're so very unique. Like you said, it's that personalized art of medicine in that sense. And then you're throwing in all the lifestyle medicine factors, which are improving things, and you're just like, it's a real, it keeps the mind sharp. Let's just put it that way on our end.
Totally. People think that lifestyle medicine, they're like,
Oh no,
can't you just leave that to them? I'm like, no. You don't understand. This gets really interesting and really crazy, really fast.
It gets really crazy. I think it's an evolving practice. I mean, because honestly, now we're getting in my practice, because, for 9+ years, I've been working on plant-based diet, but I've learning about the sleep and all these other things. And, I've always been advocating exercise and all this stuff, but it is incredible to me. The the practice of lifestyle medicine is like, it's almost like going to residency again, because it is a very different, and each patient is so different. And when they enter into the world of lifestyle medicine, they're stepping outside of traditional, just here's another pill, go out the door. It's like, okay, where are you sleeping? Looking at this. I mean, it's just so fascinating. It is amazing.
It is. It's great stuff. And it's just, I love that. I just feel so privileged that I'm able to help patients in this way. And it's just, it's so
Amazing.
exciting.
Oh,
And I love that, you're able to sort of blend the both best of both worlds,
yes,
right?
yes, yes.
So, as we've discussed, I'm a cardiologist. I use statins, but I
Right,
also love it when I don't have to. And
right.
so I think it's great that we can really, it doesn't have to be this weird dichotomy where it's one thing or the other. It's like merging them together to
Yeah.
better serve our patients.
And I think that's kind of what the new evolution of, so we had some amazing plant-based doctors who trailblazed, but a lot of some of the gurus would say, plant-based diet, forget the statins, they're harmful. No, 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 no. You're exactly right. We need to blend both worlds. And so I think that's where the evolution of plant-based diet is kind of being enfolded in lifestyle medicine. So now we're looking at the science and we're applying it to each individual. And it's really important that you have someone who understands what they're doing with that. Because I've had patients who, for example, I worked with a wife, after this happened multiple times, and maybe she was hypertensive or something else, diabetes. Well, the husband just kind of gets dragged along with the healthy diet, and he has
Always.
his own health issues.
Yeah.
And I'm always asking, it's always on my mind, how's your husband or how's your wife doing? And they're like, it's really interesting. And this happened within the last, 6 months. It's interesting. He's been really tired lately. He was feeling so good. He lost all this weight. And I'm like, is he on blood pressure meds or something? He's like, yeah, he's on two. And he goes, we measured it the other day. It was pretty low. I was like, okay, where is he? Like, you need to get over here. And we're stopping, spousal medications. He's collateral damage, right?
Totally. But that's the best part about this kind of medicine, right? Is that it
Yes.
becomes a family affair and you end
Yes.
up having not just one patient, but the whole family, right? Which is awesome.
Exactly. And what's wonderful is you can actually, in telemedicine, you're seeing the whole family. I mean, you can literally see the whole family. And I
Right.
do that. Yeah, it's so much fun. But before we go, I know at Life Right Now, I really wanted to talk to you about where you're located, how people can connect with you. Tell us everything all about Dr. Harkin and how we can become part
Yeah.
of your practice.
Yeah. So I have, as I said, a preventive telecardiology practice. It's called Whole Heart Cardiology. I'm physically located in San Francisco, but I'm licensed to see patients in California, New York, and Florida.
Awesome.
And they can find me just on my website, www.wholeheartcardiology.com. I'm also fairly active on Instagram at Nicole Harkin MD. And just follow along. And even if, you're not interested in being a patient, like I love interacting with everyone, and just it's just such a fun community of all working together to improve heart health and increase our plant intake and all that good stuff.
Well, I have a feeling this would be a very popular podcast, and we probably have to have you back on, Dr. Harkin,
I love
because
it.
I
Would be
think
my pleasure.
I think there's going to be a lot of questions that we'd spurn because we didn't even begin to touch
We
the
didn't talk about
depths.
FH. We didn't talk. I mean, there's
No.
so much more to cover.
There's so much more to cover, and it's so fascinating. But most of my plant-based docs that I know are either cardiologists or family practice, so it's a great conversation that we're having right here.
It is. I love it. Thank you so much for having me on.
Oh, well, thank you so much for sharing just even a small nugget of your wisdom and your experience. And I'm super excited, guys. You definitely see the links below, wholeheartcardiology.com. And it was just lovely talking to you. And we can't wait to have you back again.
Love it.
Bye, guys.
Bye.
Thanks for watching, and I hope you enjoyed that video. Before you go though, please hit the subscribe button and the alert button so you will be notified whenever we upload any new videos. On Monday, we upload the Healthy Human Revolution podcast. Now, if you'd rather listen to the podcast, you can find it on all the major platforms, such as iTunes, Google Play, SoundCloud, and even Spotify. On Tuesdays, we upload the Doctors In. This is where I answer your questions. Thinking of that, could you please comment below any questions you might have about health or wellness, or any topics that you would like me to cover? Now, if you're looking for more resources on how to start a plant-based diet, sustain a plant-based diet, exercise, recipes, anything regarding wellness, we've got you covered. Check out healthyhumanrevolution.com. And again, thanks for watching.